Hello friends, welcome to Dental Excellence Academy. We are today going to place an implant for 4-6, that is lower right region. For this, this is a male patient, almost 30 years old. We have a good amount of bone clinically. We took the CBCT first and traced out the nerve. You can see the width and the height that we have. We digitally planned the implant, and then we are now starting with the case. We have injected the patient, and now I'm giving the crystal incision. So can you see the amount of width we have? It is a very good amount of bone. Very rarely we could get this type of bone and the healthy gingiva. So we are now starting with the crestal incision. Yeah. In these cases, we have to go straight down to the bone and give a mucoperiosteal incision, that you have to separate the mucosa and periosteum together, because your periosteum should be with the mucosa, not on the bone, because while we are reflecting, the periosteum will tear and it will hamper the blood supply, because the total blood supply we are getting from the periosteum only. So now I'm giving a crystal, and I have given the crystal incision. Now I'm going to give a circular incision, and then we will be reflecting the flap. So isolation is very much important while you are recording the case. So in between we have to isolate. Now I am reflecting with a good sharp periosteal elevator. Your armamentarium is very important, because you have to have very good amount of good instruments while doing the surgery, and a good suction also. So we are using DAR suction. Now I am giving circular incision and reflecting the adjacent papilla also. I am not going to give a vertical incision because it is near to the mental foramina, and also the minimum trauma to the patient. So I am just giving a crestal incision and circular incision and reflecting both the flap. Now I have reflected the lingual flap also. So in any surgical procedure, you have to have a good vision and good isolation. For that, you require a good assistant, a good suction, and good armamentarium. Can you see the width, the amount of width we have? And we have determined our implant size on the basis of CBCT. You should have to have a CBCT beforehand, because if you plan your case beforehand, then only you can do it properly, and you can have less amount of implant to carry with. So if you have decided the size of the implant beforehand, it is going to help you out. Now I'm starting with the lancet drill. It is 1.5 mm drill. So you have to have a parallel approach. Most of the cases, one of the tooth is drifted, but in this case, both the tooth are straight, and I'm going almost parallel in the center. So because of the adjacent tooth, I'm not able to go deeper, but while I changed my direction, so I go deeper. So after lancet drill, you need to check for the parallelism clinically and as well as radiographically. So I have placed the paralleling pin, and now I'm going to take one X-ray so that we can see. It is almost parallel to both the teeth, and it is almost in the center. Also, you can determine whether we are away from the inferior alveolar nerve or not. Now, clinically also, see we are parallel to both the teeth. Yeah. Because of less light illumination, we cannot see it properly, but I could manage this much amount of light only. So now I we are going to start with the drilling protocol. So now I'm starting with the 2 drill, and we have decided to put an implant of 4.5 by 10 millimeters. So it is 2 drill. Now we are going to start with the actual drilling protocol, because if we go wrong in a lancet drill, we can change the direction and we can make it parallel. So you should start with the smallest drill you have. So most of the kit we don't have lancet drill. We have directly we start with the 2 drill, and in that case you can go wrong and we'll lose the a bit amount of bone in that cases. So see, because of adjacent tooth, I'm not able to go deeper. Whenever I'm going in this direction, adjacent tooth, so I have to change the direction and I'm going deeper. But I think I should use drill extender so that I can go properly. See, because of a good suction, you can see it properly. And again, I will try with the same burr without drill extender, but I'm not able to do. I'm able to do go just 8 millimeters. So if I want to go more, I have to use the drill extender. So now I'm using drill extender. Yeah. But while using drill extender, your patient should open mouth properly so that we can go straight. Otherwise, it will hamper the direction. So you can see right now I'm able to go deeper, and it is I'm going almost 11 millimeters. You have to drill a bit 1 millimeter extra because you have to go at least 1 millimeter subcrestal whenever, because you expect that much amount of bone loss around the implant, but everything is in place, then you can avoid the bone loss. But you have to consider the bone loss around the implant just beforehand. So we need to place the implant subcrestally. Now we have almost completed the osteotomy. Now we will try putting implant, but it is a mandibular bone. So in some cases you have to drill bit extra. We'll try first. If it is not going, so we have to remove the implant and again go with a bigger drill so that you will get good amount of bone implant stability. So I'm not able to go deeper. So I have removed the implant and I'm going to enlarge the osteotomy so that it become easier for me. Now this is a 4.5 drill, and I am using this drill from another kit. So it is 4.75 drill so that we get quite a good amount of occlusal flare. I'm not going till the apex because apically osteotomy is good and coronally it is lesser. And also we have cortical bone in the coronal area and cancellous bone in the middle. So we can compress the apical bone, but we are not able to compress the cortical bone in the occlusal area. So now I'm trying to put the implant. Yeah, it's going properly. Now initially we have to use our with the mount only I have placed it, but it is almost 2-3 threads above the crest of the bone. So now we have to use our ratchet so that we can go deeper. In this case, I have a good amount of bone, and so I'm not using a torque wrench, I'm using just a ratchet. This is the add-in implant 4.5 by 10 millimeter. So yeah, see, this is the ratchet and the implant driver. So you need to check whether you are equicrystal or if you want to go subcrystal. See, we have a good amount of torque. You can feel while I'm driving it. It is almost 30 to 35 degree NCM torque. With the experience, I can say this. But initially, you have to use a torque wrench so that you can check the torque. So initial torque is very important. In some cases, we don't get if we have a porous bone, that is D3, D4 type of a bone. In that case, you have to wait for more amount of time. See, you can see this image. We are subcrustal, almost 1 millimeter subcrustal. Now we have to isolate it properly because there is blood going inside the implant. So you have to isolate it properly, and then we have to put a cover screw and suture the case. So there should not be any saliva or blood which is going inside the implant. So you have to have use good suction so it will suck everything from the implant. In some cases, you have to use paper points also to isolate. Now I have placed the cover screw, and now we are going to suture the case. So we will take one X-ray so that we can confirm whether we are parallel, whether we are subcrustal, and we are not encroaching on the inferior alveolar nerve because mental foramina it is so close to our site. So we have to take care of each and every vital structure around the implant. So we will check with one X-ray and then we will suture the case. Yeah, you can see it is almost parallel and it is just away from the submental foramina. So thank you for watching and have a great day ahead.